All right, if you ever wondered what obstetric nursing is like and your assessment, this is basically it, soup to nuts, okay? Take your pen and paper out, or you can just listen freely because I'm going to be discussing it, but if you have any questions, just leave them for the end if you guys are okay with that. All right, so when you're doing a mother assessment, this is a patient who has newly delivered. This is the way you're going to stay organized. You're going to assess their vital signs, right? Heart, lungs, and bowel sounds. I want you to make sure you're making note of that. Heart, lungs, bowel sounds first. I'll just write this here. So heart, lungs, and bowel sounds. So hi, Mrs. Jones. I'm just going to come in here. I'm your student nurse today. I will be leaving at 3 o'clock. I'm going to get your vital signs. I'm going to take your blood pressure, listen to your heart, your lungs, and your bowel sounds, and assess your pain. And then I'm going to do an obstetric assessment, okay? When you do the obstetric assessment, you're not going to walk up to the patient and just begin with the physical assessment. You kind of want to ice break a little bit with your patients, right? So ask them, how are you feeling? How was your delivery? Did you have a boy or a girl? Did you know you were having a boy? Did you know you were having a girl? Try to strike up a little bit of conversation beforehand so they at least get comfortable with you, all right? Okay, so first thing we're gonna assess, after we do the heart, lungs, and bowel sounds, we're gonna assess, what's the first B? Anybody wanna guess? Breast, okay. All right, as far as the breasts go, they're used to breastfeed a baby, or sometimes they're not used for any feeding purposes. And there's 2 things we need to teach the patients depending on what their decision is. So we're gonna go with non-breastfeeding moms first. So these are the moms that have decided to solely use formula or another means of feeding, okay? When we are trying to dry up the milk supply, we know milk supply is initiated at the time the placenta is delivered. So when the placenta comes out, we know that the prolactin levels increase, and that allows for milk production to begin. They will produce colostrum after 24 weeks of gestation, but they won't be able to maintain a life without having that placenta be delivered. So if we are not going to breastfeed, what do we want to do to the milk ducts of the breast? Stop them from producing milk. How do we do that? All right, so think of the breast like a tree and a bunch of roots. The breast, the roots are going down to the nipple end, right? All of those roots need to be vasoconstricted because we want to do what to the milk? We don't want it to come in, right? So we want to vasoconstrict those milk ducts. So what things are we going to do that?
Apply ice.
Apply ice, because what does ice do? Vasoconstricts the milk ducts. What else are we going to do? We don't want to dilate these ducts. No heat, because heat's going to open them. So we want ice. Pressure. So this is the whole rice thing, you know? Right? Rice is what?
Ice.
Compression, elevation, right? Now we can't rest our breasts, please, you know, but think of it that way. When we're trying to decrease milk supply, you want to compress them. Now I can't walk around my house holding my boobs all day compressing them. So what am I going to do?
Wrap them.
Wrap them. Now am I going to wrap them and stand up and turn around with an ace bandage? No. What am I going to wear? Sports bra or a tighter fit cup bra. So if you're a C, go with a B. Or wear your old bra before pregnancy, exactly, because the girls will not fit in the same cup after that. No. All right, so we're compressing them with a supportive bra. That's a key thing you need to use. Supportive bra, maybe a cup size smaller. The bra should have no underwire. Why? Think of the roots of the breast duct. Think of them. If I put a wire against some of those ducts, what happens to the ducts? What am I doing? It's compressing them, right? Which can increase the risk for something called mastitis. Mastitis, M-A-S-T-I-T-I-S. And that is inflammation, infection of the actual milk duct. All right? It's unlikely that bottle feeding moms get mastitis because we never really get their breasts full of milk, but that risk factor is there. So it's important to say to your moms, I want you to use ice, supportive bra. When you wear your bra, it should have no underwire bra. When you take your shower, we should do what? Do I want? Well, if you're getting your milk supply in, your breast will leak. Because what does a shower do? The heat dilates the ducts. And what do we want to do? So what do we want to tell our patients to do? Do not tell them to take a cold shower. If you've ever given birth, I mean, really, now we're going to make her take a cold shower? That's just torturous. So what am I going to tell her to do with her body? The shower head's here. What am I going to do?
Turn your back.
Turn your back, okay? Don't be standing there like this in front of the shower head getting your breasts all warm, because that's going to tell your milk ducts to open up. So face your back to the shower head. Try not to get them too warm, because that's going to bring all the supply in. This is for moms that are bottle feeding, remember, okay? So warm showers, not facing the head of the shower. Supportive bra, no underwire, and ice. They also advocate for using cabbage leaves. Cabbage is a homeopathic remedy. If you have a sulfa allergy, you are not allowed to use cabbage leaves, all right? Because sulfa is in cabbage. So if you have a patient with a listed allergy of sulfa, don't tell them to use cabbage, because then they're going to bust out with a mean rash on their breasts, and then they're really going to dislike you. So you're going to put cabbage. You literally will put the head of cabbage, peel off the lettuce, stick it right in the bra against your skin. Then you're going to take a frozen bag of peas, stick it in there too, or an ice pack. Supportive bra, no underwire. Limit your showers to your back, right? And you can take Motrin or Tylenol to help with some of the inflammation. That is how we dry up your milk supply. How long does it usually take to dry up your milk supply? How long does it take to bring in your milk supply? 3 to 5 days. It usually takes about 3 to 5 days to fully dry up your supply. If the mom feels breast fullness and she's trying to dry up her milk supply, some moms will hand express and squeeze out breast milk to alleviate the pain, because when the milk does come in, it's not comfortable. So you need to make sure you tell her not to do what? Do not squeeze it out, and do not pump it out, because the laws of supply and demand apply directly to this. If you tell the breast milk to come in, it will come. So alleviating the pressure from the fullness is actually going to tell your body to make that much more milk the next feeding. So no stimulation to your breast, no heat to your breast. It's cabbage, ice, supportive bra, Motrin, no underwire.
So what do they do if they become engorged? Like how do you?
That's how you do it.
Oh, like that.
Yep. All right. Now mastitis. What did I tell you mastitis was? Inflammation and infection of the milk duct. Okay? It's not inflammation, it's not infection of the milk itself, which is why the moms that are breastfeeding can still breastfeed. We'll get to that. But symptoms of mastitis will be similar to a deep vein thrombosis. What would we feel? When we're feeling around, it's going to be hot to touch, like a warm spot. Extreme pain. This is not something she's going to be like, honey, I think I might have mastitis. This is like, oh my God, this is really painful. I can push everywhere else except for here. It'll be a red streak, red line, hot to touch, extreme pain, flu-like symptoms that come on really fast. We're talking like 6 to 12 hours. It comes on really fast and you get a high fever, like 103, 104. You need to call your OB doctor, not your general practitioner. Anything over the first 6 weeks postpartum gets immediately directed towards your obstetrician. Okay? So if you have any signs of mastitis, redness, red streaking, hot to touch, extreme pain, flu-like symptoms, you need to call your OB doctor. What they may need to do is lance that area open and drain it. They may need to just put you on antibiotics. They may tell you to just pump and get all that breast milk off to relieve some of the inflammation to prevent further exacerbation of infection. Make sense? Okay, all right. So that's for the bottle feeding mom. Now we're talking about the breastfeeding mom. Okay, so the breastfeeding moms want to do what? What do we want to do with the breast? We want to produce milk. So what are we going to tell her body to do? What are we going to do to her breasts? Stimulate. Now, what does that mean? Twirl my nipples in my hands? What?
Have the baby.
Have the baby latch. So before you even start saying, well, pump, isn't the baby the best pump that there is? When you have a baby against you, the body's warmth, the smell of the baby, the crying of the baby, just looking at the baby, all of that stuff stimulates and secretes hormones in the mother's brain to produce more milk, versus an artificial plastic plug in the wall mechanical stimulation. Does that make sense? Noisy, yeah. So when we're trying to get our milk supply in, stimulate, stimulate, stimulate. The more often you latch that kid, the longer you let that kid latch, the better your milk supply will be. How long does it take to get your milk supply in?
3 to 5 days.
3 to 5 days on average. It may come in sooner for some moms, it may come in a little bit later for others. But the key thing is that we stimulate. What's another thing we can tell her to do? Use heat. All right, give me examples. How are we going to use heat? And do not say heating pad.
No, warm wash.
Warm washcloth, yep.
In the shower.
In the shower, absolutely. A lot of people will say, let's put on like a, a heating pad. But you gotta plug the heating pad in. And I don't know about you, you give birth to a baby. You can't sit there with a heating pad on your boobs when your kid's crying in the bassinet every 5 minutes, it feels, right? So make it realistic for them. Take 2 warm washcloths, get them warm, smack them right on your breasts. 5-10 minutes before you breastfeed. That'll allow for some of that pooling of breast milk to come to the edge of the breast to make it easier to breastfeed, right? Stimulation, warm showers. What else are we gonna tell her to do? Now, when you fill a water balloon on the sink, you ever do it? Put it around the spigot and you fill it. What does the balloon do?
Save.
It sags and it goes,
So
right?
She should always wear a bra.
She should always wear a bra. Because if she's got nice perky breasts now, she's not gonna be as perky when the milk comes in. Okay? They're gonna hang a little lower and they're not comfortable when the milk comes in. So using some supportive bra that's again not underwire, and we don't want to go and compress too tight, so we don't want a size smaller. We want an appropriate fitting bra that gives enough support to lift them but not to compress too tight. Okay? No underwire, and we want to make sure it's supported. All right, and then signs of mastitis again are what? Feel free to speak loudly.
Red streak.
Red streak, hot to touch,
Pain.
extreme pain, flu-like symptoms, high fever, yep, fever of 103, 104. This is not like 100.1. This is like a raging high fever. Okay? Great. When you are doing your breast assessment of a breastfeeding mom, we're not just checking the breast tissue. I'm not going to be going around and doing an actual breast exam checking for tumors or masses, but I'm going to do a visual inspection for mastitis on both the bottle feeding mom and the breastfeeding mom to make sure she doesn't have mastitis. And for the breastfeeding moms, I'm also going to do a nipple exam. Now, nipples come in all different shapes and sizes. All right? There's dark ones, there's light ones, there's small ones, there's big ones, there's hairy ones, there's tattooed ones, there's pierced ones, you name it, they're out there. There's meatball looking ones, there's flat ones, there's inverted nipples, crazy business. And to the women that are breastfeeding, their nipples have been their nipples their whole lives. So don't be going up in there and being like, oh my God, I've never seen a nipple like that before. Because the mom's probably like, oh my gosh, I thought they were normal, right? And then you got a hormonal woman, now really hormonal because you made fun of her nipples. So when you're doing your nipple assessment, identify what kind of nipple you're looking at, right? The anatomy, because the anatomy of that nipple is going to dictate to the nurse how we intervene if the baby's having breastfeeding latching issues. All right? The other piece is if she has an inverted nipple, which we'll discuss later, but an inverted nipple may not allow the baby to latch on properly and move the milk because the nipple actually folds in. And every time that baby sucks, the nipple folds in and the milk doesn't come out. So the kid's sucking, but the kid's faking this out the whole time. The only way you're going to catch that is if you know how to assess the nipples. Are the nipples damaged? Are they bleeding? Are they cracked? Are they bruised? Are they blistered? And by the way, that does happen. You ever wear a pair of sexy high heels to a wedding or brand new sneakers? You dance in them all night long like a rock star, and then you get in the in the car on the ride home and you take your shoes off and you're like, oh my God, my feet, I got a big blister back here. Then you gotta put the shoes back on and walk into the house and wear the shoes all day the next day. That's basically the description I give patients about how your nipples will be feeling for the next about week to 2 weeks. You basically have to wear down that tissue a little bit, strengthen the nerve endings so it can tolerate all that wear and tear. It's not the most glorious experience when you're beginning to breastfeed because you are going to unfortunately create some discomfort to yourself when your baby latches. So key thing with latching is that they open their mouth wide open when you put them on, and that mom's not experiencing pain the entire breastfeeding event. And we'll go through that with lactation as the semester goes. And don't pull them off. You break the suction by putting your finger in their mouth. Let's get them to break that suction. You'll hear like a little pop noise. And then the kid will come off versus pulling the nipple with the kid. I've seen that. Okay? All right. So we got 2 pieces. Are we drying up the supply or are we bringing the supply in? And mastitis, you guys know for both. I'm just going to write that here because both of them, you both have to teach about mastitis. When I get done teaching them all of this stuff, I'm going to then say, Mrs. Jones, I'm going to check your breast now for mastitis. And wouldn't you say you guys would be like, oh yeah, absolutely. I totally know what you're checking for now. Versus me just walking up to you and being, I'm going to do a breast exam and like snap, snap, snap. So you're going to educate first, then check. And that's how we're going to do each one of these. Breast. Next is what? Anybody want to guess?
Uterus.
Good job. The fundus. Okay. You only got one. You only got one in your whole life. So that house is what holds the baby. The fundus. All right? Right now, not being pregnant, your uterus should be on the lower pelvic floor. Really low down. That's what's cramping when we get our cycles every month, right? And then when you get pregnant, it increases with size and it moves upward because the baby's growing. When you're halfway through your pregnancy, how many weeks is pregnancy? 40 weeks. Your uterus, generally the top of that ball sits at the umbilicus or the belly button. So it's about that big. Baby's floating around in the bathtub. Top of the ball is felt right here. And you feel that by putting your hand inside of, like against the tissue of the mom. You feel down until you feel the top of that ball. When you're 40 weeks pregnant, where would you imagine it to be? Ooh, up high. Which is why you see like women at the food store. Because the top of that uterus is pushing on what? On what? The diaphragm. So when she's taking a deep breath, can she take a big deep breath? No, because that uterus is blocking it. And then you got the kid kicking around with amniotic fluid and a placenta. Add it all to the mix, right? So the uterus, when they immediately deliver, the uterus is the basketball. Whoop. The kid comes out. That uterus then should do what? Shrink back down. Ideally, the uterus should shrink within minutes of delivery, minutes. And it should be right here. The top of the ball should be at the umbilicus immediately after delivery. For every single day of post-delivery, the uterus should go 1 centimeter or 1 finger breadth below the umbilicus, okay? Everybody with me? So if she's a 2-day vaginal delivery, where should her uterus be? 2 centimeters below the umbilicus, right? If she's a 4-day C-section, where should her uterus be? Ooh, trick question. She threw in the C-section. 4 finger breadths below the umbilicus. It does not matter how your baby is delivered. The uterus involutes the exact same way, okay? If she is a 2-day vaginal delivery and she's 4 finger breadths below the umbilicus, am I going on my lunch break?
No.
Yeah.
I'm not saying you're wrong. I want you all to think about this. She's 2-day vaginal delivery and she's 4 below. Which way should her uterus go? Which way do we want it to go? Down, right? And is she ahead of schedule or behind schedule? Ahead of schedule. And wouldn't you say, in most cases, being ahead of schedule is like, good for you? That's exactly the case. What that means is that uterus is contracting at a faster rate than what we expect. And that's not going to create any damage to her, besides just feeling a little bit more uncomfortable. Because as that uterus involutes, how do you think she's feeling? Feeling a little crampy, which is a great sign as the nurse. I'm like, I'm really sorry you feel so bad, but yes, I can go on my lunch break. See you later. Okay? So if she's ahead of schedule, great. But if she's behind schedule, we're in problematic central. I'm not going on my lunch break. For instance, she's a 3-day vaginal delivery and she's 1 above the umbilicus. So she should be here, but she's here. All right, it's not good. I don't know why that's not good yet, but you understand that it's not what we're expecting. So the uterus should always move down, and if the uterus is not moving down, or it's not ahead of schedule, or at schedule, you need to intervene or be thinking outside the box as to what the problem is, okay? The uterus can move to the left or to the right. That ball should be where? Midline. Midline, nice and firm, like hard as a rock. If it feels like ground beef, sorry for the analogy, or pizza dough, we got problems. That's called a boggy uterus. A uterus that is well contracted will involute down. A uterus that is relaxed is going to allow bleeding to occur. Okay? All right, I know this is a lot of information. Try to stay with me. Try to stay with me here. So now I got the big basketball. Are we with me? You got the basketball. I'm going to ask you a quick question. I want to see if you can pay attention because this is not always easily understood. You got the basketball. Inside of the basketball, which is the uterus, you have a placenta, right? The placenta is like the sticky hand. You know the sticky hands from like the 1980s that you paid 25 cents and you like stuck them to the ceiling and they had this sticky string arm and it slung off and you left a goopy stain on the ceiling? Think of the placenta like that. The sticky hand is stuck to the side of the basketball and the string is attached to who? The baby. That's the umbilical cord. You guys staying with my analogy? And you got the baby now floating around in a pool inside of the basketball, right? Okay, so what comes out first in delivery?
The baby.
The baby comes out. And then what does the doctor do? Cuts the cord. And now the kid's out in the side, you know, crying, smiling, taking pictures. And then the mom has to deliver what? The placenta. So what does the sticky hand have to do? Release. It has to come off. So here comes the sticky hand. Each little finger is coming off. And it basically plops out into the bowl, out of the vagina. And what does the uterus do then? Starts to contract. Now, what is bleeding? Why does a mom bleed?
From the placenta coming away from
From the placenta coming away from the wall, okay? So if this uterus is contracted, does it allow the placenta area to bleed? Right. That's why we need that uterus to constantly maintain contractility. Does that make sense? Are you with me? So if you get cut in your arm, the first thing you're going to do is what? Before you call somebody, what's your initial gut reaction? Apply pressure, right? The uterus, I can't apply pressure. Even if I wanted to, can't get to it. What is the uterus going to do to itself? Compress it itself. So if that sticky hand area is like a scab that needs to scab over, right? If that fresh area with capillaries coming through and it's bleeding and the uterus becomes boggy, what's the mom going to do?
bleed out.
Postpartum hemorrhage. Are we understanding? So that uterus needs to maintain contractility at all times. If it doesn't, we need to intervene. Make sense? Oh my gosh, look how much more you've understood. Crazy. All right, so breasts. We're going to be like a choir now. You ready? Breasts, uterus, nobody knows. Bladder. Bladder, bladder, bladder. Bladder. If you guys need to stand up and walk because I'm talking a lot, it's fine. I'm just letting you know. I see a couple eyelids like going. I gotcha. And for those of you listening, if you're getting bored, put pause. So for you guys right now, what I want you to do, just pay attention here. Breast, uterus, bladder. Where is your bladder anatomically against the uterus? Where's your bladder? Well, it's somewhere down here.
It's under the
What are we saying?
retroperitoneal.
Retroperitoneal area. Woo! Good for you. What does that mean? It's below the uterus, slightly behind. Okay, think about this. The bladder is a bag, is it not? If that bag fills and fills and fills, where is it going to push the uterus? Think about it. I need you to stay with me. It's up. You're right. I need you to think about that though. So if the bladder fills and fills and fills, and we got this ball here, it's going to force it to go up and deviate. Make sense? So the first inclination to yourself as a clinical practitioner, if her uterus is deviated or boggy, as we like to say, we're going to massage the uterus. We're going to massage it. Like literally put your hand in their stomach and rub it to make it contract down. And we're also going to ask her a few questions. Like what?
Does she have to pee?
Yeah, do you have to pee? Or when was the last time you peed? And most moms will be like, it's 3 o'clock right now. I guess it was like 7 a.m. I just didn't want to get up because like the pads and the ice packs and like the underwear, and then my mother-in-law was there and I didn't want to like shower my backside and I was bleeding. I just figured I'd wait until they all left. That's a true story. Patients do that all the time. But if she understands that her bladder can affect how her uterus contracts, she'll probably be more inclined to get up. How often should we be peeing? Every 2 to 3 hours. Every 2 to 3 hours, she should be getting up and peeing. Keeping that bladder empty is going to ensure that the uterus contracts and moves down. Make sense? All right, and then we're going to ask her signs and symptoms of what? What goes along with the bladder in med-surg world? UTI, thank you. What are the symptoms of UTI? Pain.
Urinary retention.
Urinary retention. Frequency.
Pain. Oh, what's it again?
Yep, urgency. Cloudy fluid. Foul smelling. You're going to ask her all those things. Now, what's one of the topics you're going to ask about a UTI that she may say yes to? Well, do you have any blood in your urine? The answer is going to be yes, but it's not from a UTI. It's from the L, which we haven't gotten to yet. Stay tuned. What other question? Do you have any burning on urination?
Oh, yeah, that's from a
She's going to say,
stitches.
yeah, absolutely, because of the E. Stay tuned. We'll talk about it. But for right now, if she's burning on urination, do we think she has a UTI? Yes, according to the textbook. But if she's stitched vaginally, how are you going to be able to tell? What are you going to use? What are you going to tell her to use when she pees? The peri bottle. Tell her to squeeze the peri bottle while she's peeing. If the burning goes away with the peri bottle, is it a UTI? See that? You just eliminated a risk factor for a potential UTI diagnosis that she never even had. Okay? So you're going to ask her those questions. And then you're going to tell her, and you're not going to say, do you have any burning on urination or things like that? No. You're going to literally be like, do you have any burning? Urgency, right? Hesitancy, where you run there real fast, you gotta go, you sit, and it's like drip, drip, right? And when you empty your bladder, do you not feel like you're emptying it all the way? These are the questions you have to ask them. So make sure you're covering UTIs and ask her when the last time that she peed, and then how often should she be getting up?
2 to 3 hours.
Every 2 to 3 hours, and if she does that, she's gonna decrease her vaginal bleeding. You with me? All right, folks, what did I tell you? First fear is to give birth. Second fear for breastfeeding moms is that they'll suffocate their kids' face with their boobs, and that won't be good. And the third fear is to do what? Poop.
Bowel.
You got it. Breasts. Come on. As a choir, uterus, bladder, bowel. Okay, bowel. How long does it take a woman that just gave birth, C-section or vaginal delivery, to poop?
5 days.
You got it. Takes 3 to 5 days for most women. Okay? So that means if they're an everyday pooper and they just gave birth, oh my God, they're scared. Okay? And if they're a every 5-day pooper and we're telling them they take 5 days, they're scared too. So what are we going to tell them to do? Here we go with the meds. Stay away from the meds first. Let's do more homeopathic ways. What can we tell them to do? We want her to have a softer stool. Increase your fiber. Fluids.
Walk around.
Get around and walk. Ambulate is great terminology, but not everybody knows ambulation, right? Remember when you're in your patient rooms, keep the terminology to the basics. Okay? So bowel movement, they may not understand what that is. And that's not to discount the patient's knowledge. It just may not be, it may have been their whole lives that they've said the word poop. You might have to say it, so practice it in your cars driving to clinical. When's the last time you pooped, Mrs. Jones? That's the other thing you want to ask her. Because if she hasn't pooped since last Tuesday and it's Sunday, and we're discharging her home, she needs to know where the 5-day window is. Know what I mean? So you're going to say to her, Mrs. Jones, when's the last time you pooped? And she's going to go, all right, Sunday. I came in on Friday night in labor. Thursday, I had my nail appointment. Yeah, it was after the nail appointment. Oh, it was Thursday. It was Thursday. Okay, it was Thursday. And then her support person's going to be like, no, that's not when you pooped last. And the patient's going to go, what do you mean? And that probably is maybe that they delivered a little bit of a baby and a bowel movement. When they push effectively, they are pushing with the same muscles of their rectum. So if I see poop moving, I'm actually thrilled because then I know that she's pushing effectively. Does that make sense? They don't know that they're pooping. And as an obstetric nurse, I'll tell you right now, I just wipe it away. I don't say a word about it. Because if I tell her that, what's she going to do? She's going to be like, oh my God, I can't poop on the table too, right? So we just very modestly remove that, okay? But I want you to know that's typically when you'll see a patient have a bowel movement, is when they're pushing effectively if they didn't have a bowel movement before they were admitted. So find out from her, when's the last time you had a bowel movement, and educate on what she needs to do to have a bowel movement. 3 to 5 days is what you expect, normal range. Increase your fluids, your fruits, your vegetables. Get up and walk, and take your stool softeners. Got it? Great. Like a choir, folks. Breast.
Uterus, bladder, bowel.
What's next? Who wants to say it? Lochia. Now this is not the time to say, Mrs. Jones, how is your Lochia? Because if you don't know what Lochia is, she won't either. Lochia is vaginal drainage. It's not menstrual cycle blood. Understand? It's 2 different things. Why are we bleeding? We just had a baby. Well, what does that mean? Where's the blood coming from then? The cervix? The uterus? What about the uterus? Where in the uterus?
Well, remember it was contracting.
Okay, so it's contracting.
And from the
Yes, guys, that is what it's from. The Lochia is the blood that's left over, the trickle of blood left over from where the placenta used to be. Have you ever gotten a cut on your arm and you put a Band-Aid on, and then we get that blood that's bright red on the Band-Aid for the first day? And then you take the Band-Aid off and you change it, and what color is it usually a few days after that? Like a pinkish peach color.
Oh, yeah.
Like a serous sanguinis fluid, right? And then it gets to what color? Brownish. That's what we're dealing with here. So Lochia is vaginal drainage, okay? Coming from the placental area. And this is how it goes. 1 to 3 days, it's bright red bleeding. It's called rubra, R-U-B-R-A.
Press 1 to 3.
Got it? So you're gonna bleed for up to 6 weeks, Mrs. Jones. And she's gonna go, oh my God, are you kidding? And I'll say, no, you didn't have your period for 9 months, so I guess it's back to bite you in the butt in the end, huh? 1 to 3 days is bright red bleeding. Days 4 through 10 is peaches pink, similar to your menstrual flow. So gentlemen that do not have their menstruation, when you're teaching this, or ladies, if you don't know what a normal period is like, it starts, it's bright red, like the start of your period, pinkish peach, like the middle of a period, to a brownish white creamy discharge for 11 days up to 6 weeks postpartum. By then, the area that the placenta had attached should be completely resolved. Does that make sense? You could bleed less than that, make sense? But you shouldn't bleed any more than that. So if you've got bright red bleeding and you're 12 days out, do we have an issue?
Yeah.
We have an issue. Okay. Or if you pass any clots bigger than this size, that would be a $50 or a poker chip. Do you guys know what clots look like?
Yes.
Go into the jelly jar, take a spoonful of jelly. That is what a blood clot coming out of the vagina looks like. Dime-sized little jelly things, I'm not worried about it. Stringy little things once in a while, not a big deal. But anything bigger than that $50. So if you have to put your index finger and your thumb together, I want you to do that to your patient. You need to give them a visual because they don't understand necessarily the size we're talking about. Or if you're soaking a pad in 1 hour. So one vaginal pad, I want to just show you what I'm talking about. If they soak this sucker in 1 hour, 1 hour, and it's soaked from the top to the bottom, bright red, where you could wring it out, we have issues, okay? But if she's Mrs. Jones, who was asked when the last time she peed, and it was at 7 a.m., and it's soaked, am I worried?
No.
No. But technically, she should be going to the bathroom to do what? Which means, shouldn't this be changed every 2 to 3 hours? Does that all make sense? They kind of all link together. You guys are doing great. Stay with me. You ready? Here we go. Breasts. Come on, guys. Start over. Breasts.
Uterus, bladder, bowel,
Lochia. Yeah, you're all saying it good now. Episiotomy / incision. And I do both here because you know you can deliver vaginally and get an episiotomy or a laceration, and you can also have a C-section incision, right? So that I combine them both depending on your patient. All right, episiotomy is when you have a pair of scissors that are being placed in your vagina and cutting into your perineum. I am not an artist, and my kid would probably be very upset with me if they saw the way I draw this, but just stay with my way of drawing, okay? Anybody? Urethral meatus, vaginal area, rectum. All right, there we go.
the bottom of
There we go. Now we really got a view, right? Okay. All right. Right?
Yeah.
Okay. Look, the doctor's coming in. We're doing an episiotomy. Why would we do an episiotomy?
You can't get the baby out.
To get the baby out. Why would we need to not do that on some versus others? Baby needs the hole to be bigger. Exactly. Maybe the mom's perineal area is really, really small and tighter, and the kid's noggin is really big because they have a really smart brain. Right? If that's the case, we got to do an episiotomy. Or maybe their head comes out and their shoulders are stuck. Right? Okay, so the doctor's physically going to take a pair of scissors and go into the vagina, and they're going to cut. Now, if you were doing this, where would you want to cut? At the bottom. So we're going here?
Inside.
Yeah, inside. So I'm going in. But I'm going to cut down. I got to open it up. Where do you want me to go? Which way? Sideways. All right, she wants to go down. You want to go sideways? Up and down? And you want to go sideways? Yeah, I know, but which way am I cutting? Am I cutting it to go straight down, up? Okay, we got two ways. Are you ready? We got one person saying this and one person saying that. It's amazing. It's always the guys that get it right. I don't want you handling my vagina. Because guess what?
Oh, that's going into.
It's going right into the butthole, right into the rectum. I'm telling it, Hail Mary, you gotta rip right through it. But if I deviate it to the side, as my friend over here, the gentleman without the vagina, tells me to go to the side, yeah, right? It's gonna tear here. Now, I don't want it to tear at all, but if I had to have my choice, I'd much rather deviate into my butt cheek than go into my butthole. Are we all with me?
Yeah.
Okay. So that's an episiotomy. And we can have a left line mediolateral episiotomy where it's to the left, or a right. But I sure as hell do not want to be dealing with her idea. Woo! That's basically saying, yeah, look, we only got about a ½ inch and let's just make it go right through it. So that is an episiotomy. We're controlling a laceration that's going to be far worse than the doctor would like to see naturally happen on its own. So the doctor sees it's tearing, and it's tearing right straight for the hole, the rectum. What does the doctor want to do? Intervene, deviate, cut to the side, redirect to the butt cheek so that we don't get an involvement of the rectum. Make sense? Okay, so that's an episiotomy. Now, I told you guys, you got to be knowledgeable about the OB doctors and hospital that you're at. You should also be really knowledgeable in how well your doctor handles situations like this. So when you meet your OB, you should ask him, like, what's your deal when you're ready to deliver? Do you just show up with your booties on and catch the kid? Or do you hang out with me a little bit while I'm pushing at the end? It's a big question. Why? Because what's going to happen is you're going to be in the bed and your doctor's going to come in. Your doctor's a good doctor. Your doctor's going to do this. Put on a pair of sterile gloves and say, nurse, get me some petroleum lubrication. And the nurse will open it up on her sterile gloves, and then what will she do with her hand?
Check you.
I'm going to check, but I already know she's 10. I can see the kid's head. The hair is looking at me. Your doctor, if they're a good doctor, will go like this. And what am I doing? I'm lubricating, so let's grease the baby out. Good idea.
Stretching.
I'm helping to stretch. So I did a 5K yesterday with my 9-year-old. I survived, I can't believe it. But before I did it, what did I do? Stretched. Vagina's a muscle, is it not? It's tissue that has to acclimate stretching. So if the doctor didn't have all the time in the world and just showed up Come on and push. Go, go, go. Push through that. And she hasn't had any workout. What kind of damage is she gonna have? Might be worse than what she would need, right? So if your doctor's really on the ball, we should be lubricating and massaging that area to help stretch the muscles to get ready for the marathon. Make sense? Okay. Giving birth, it's a workout. I've been there 3 times to know. All right, so when we have a laceration, lacerations can go anywhere. Okay? Anywhere, doesn't matter where, but it's the degrees in which we're worried. So you have 1st, 2nd, 3rd, and 4th degree tears. 4th degree tear, guys, goes all the way through the muscle wall into the rectum. For a 4th degree, it will look like this. You are now pooping and having your period at the same exit. Okay? You don't want to have a 4th degree tear because then the doctors have to do rectal surgical repair in a sterile, fairly clean area with a very fecal, dirty area. How well are you going to heal? It's going to be a long haul. Makes sense? So you can have a 1st degree tear. They're like the least that you can have. It goes through one layer of the tissue. I would say about 80% of the moms in postpartum have a 2nd degree tear. It's through 2 layers. And we don't count stitches, okay? If your patient says, how many stitches do I have down there? You know how many stitches on your arm? It's like, I got 15 stitches on my arm. Yeah, we basically keep sewing the doctors until it's like a zipper, until it closes. It could be 4 stitches, it could be 1 stitch, it could be 15 stitches. It could be more. So we don't count the stitches. We go by the depth in which the tissue are affected, okay? So you can have a laceration, which naturally occurs on its own, or an episiotomy where they actually cut, and we don't want to be cutting her way, okay? And if we don't, so we just talked about that. That's when we're going to use ice for 24 hours, right? Ice, 24 hours, and then what? Heat to help with vasodilation to get all the cellular flow. Make sense? And then the hydrocortisone cream and the tux pads. Incision, we're dealing with this. So C-section. For the first 12 to 24 hours, they get a dressing put on over top of it. It's a square one, it goes right over top of the abdomen. You got your belly button here, okay? What's your job as a nurse when you do the incision check? 1, do not take the dressing off if the dressing's on. So we're looking at the dressing, and what are we going to do? What are we going to look for?
Like if it's bleeding through the dressing.
Okay, if it's bleeding through the dressing. So hypothetically, let's say that's the blob. What am I doing as the nurse?
If it's like that, can you pull it off to actually look at the incision?
I will definitely not take the dressing off yet, but I know where you're going. There's the blob. What am I doing as the nurse?
Apply pressure?
All right, fine.
Not wanted. No, not wanted.
Where am I putting blood pressure on?
Above or below, not wanted though.
Okay, all right, there we go. I'm taking her nursing idea. Here we go.
This is for cardiac care.
Now what? Cardiac caths are a little different than giving birth, but let's go with your idea.
Well, can't you see what kind of a blood?
All right, so where? You want me to look underneath?
No, like look at.
Okay, I'm looking at it. It's like it's a shadow. I can tell it's red under there, but it's not like through the dressing, but it's that size. I'm applying pressure now.
Would you go put more dressing over it?
All right, fine. Now what?
Go get the doctor at this point.
All right, I'm gonna call the doctor. All right, fine. Now I let go of both and I go call the doctor. Hello, Dr. Jones. I have a patient who has a dressing that has about, I don't know, a 3-inch by 2-inch drainage on the dressing.
Put some ice on that.
Now the doctor's response is, what are you telling me, Nurse Jen?
Come down here, they bleeding.
Well, come down here, they're bleeding. Well, how do you know if it's an active bleed or not an active bleed? Are you really gonna waste my time pulling me out of a labor and delivery experience to come and check a dressing?
Yes.
Okay, fine. As a new nurse, have the doctor come always. But really, think about this, folks. You got a dressing, right? And you got this blobby guy going on. And I want to apply pressure, but how long can you apply pressure for? What are you gonna do? How do you know if it's even active?
Yeah, the old dry bladder.
Color. All right, so it's bright red and it's staying the same. She just had a C-section.
Yeah.
Well, like if it keeps growing.
How are you gonna know?
Monitor it for a little
Monitor
bit,
it.
come
What do you
back.
mean?
Just check
Look
it
at
every, no, like check it every
Measure it.
time.
Measure it. Bring it out. This is painful. I'm pulling it out of you guys. What am I gonna do? You're right there, but how am I gonna do it objectively?
Put a line on the dressing.
Put the line on the dressing. Oh my gosh, there she goes. What I'm trying to teach my 5-year-old to do is trace objects, yes? Take your pen and blobby guy around it. And what am I gonna do there?
You can see if we could figure it.
But what am I gonna do? You got it. Now, when I walk away to go call the doctor, or when I walk away to go give a Tylenol to my friend down the hallway who needs medication, and I come back at 15:20 and I see nothing changed on the dressing, what do? All's good in the hood. Great. Back to my next assessment. But if I see it goes out this way a little bit more, about that much, am I impressed? It's probably just soaking a little bit from whatever it was before. But if I see like this and it's only been 10 minutes, now I can call the doctor and say, hey doc, SBAR, situation background assessment recommendation. Hello doctor, here's the situation. My patient had a C-section. Her dressing is showing active signs of bleeding because at 15:13, it was a certain size, and at 15:20, it was expanded. The patient's not showing any other symptoms at this time. Right, so that's the situation, the background, she had a C-section, SBA, right? Is it making sense? Background, assessment, recommendation. My recommendation is that you come over here, doctor, to assess the patient. Click. All right, so that's how that goes. So you mark the dressing. So if we have a dressing, you're checking it for any signs of drainage. If you have an incision, you can have an incision that's glued shut, sutured shut, or stapled shut with steri strips over top, okay? That's when we do Rita. Tell me you know this. Oh no, cold spa? Really?
We haven't learned anything about suturing.
No. You have to tell me. If you have any signs of an incision, a wound healing.
Redness.
Okay, yes.
Swelling.
Edema. Oh, you don't have a mnemonic?
No.
Okay. Oh, Lord. Okay. I'm really not doing well with my verbiage on this video here, but I'm going to just stay with what I'm saying. Redness, edema, erythema, drainage, approximation. That is how you assess an incision. Got it? If it doesn't have one of those things, you better call that doctor. Is the incision opening up? Is there like some white pus coming out of the incision? Is it bright red? Is it bruised so bad that you can't, like, that you can actually define where the purple coloring is? All right. Watch the video, folks, if you can't write it down fast enough. All right. Okay, here we go. Stay with me, folks. Here we go. Breast, uterus,
Bladder, Bowel, Lochia,
episiotomy, / incision. Say it again now. Breast. Don't look at the board. Uterus.
Bladder, Bowel, Lochia,
Episiotomy, / incision. H. We're in the home. We're in the home stretch. Home and sign. All right, guys. On your NCLEX exams, we no longer do the home and sign because home and sign is when you dorsiflex the foot. You push the toes towards the chest, and you ask the patient if they have calf pain. That we no longer do because what we've learned when we're assessing for a DVT, deep vein thrombosis, we don't want to dorsiflex because that might dislodge the clot and kill the patient after all. But we still need to teach it because it's on the boards. So the home and sign is when you dorsiflex the foot. You are not going to be doing that at clinical with me, okay? But you would normally dorsiflex the foot passively. You don't ask the patient to do it, you do it for them, okay? We're not doing that. But I want you guys to ask a couple questions to assess for a DVT, deep vein thrombosis. Hi, Mrs. Smith, I'm going to check your legs for a blood clot. Do you know what a blood clot is? They may or may not know. And this is what it would look like if you had a blood clot. Red streaking, hot to touch, extreme pain, abnormal swelling in that leg comparatively to the other, right? Similar to what other diagnosis that we talked about today? Mastitis. See that? You're learning so much. So you're gonna check for those things. So Mrs. Jones, I'm gonna check your legs for blood clots. 2 legs, gotta check them both. Feel underneath, look underneath the legs. Then we're also gonna check for pedal pulses. Check for pedal pulses, guys. And then you're gonna check for edema, which is what? Edema. Swelling. You're gonna check for pitting edema on your patient's feet. Questions about that? You're gonna ask her, do you have any redness? Calf pain, right? Warm spots, all right? These are the big things you want to make sure you're asking her. So you ask her, are you having any calf pain at all? And if she's not, then you can just continue along with the assessment. Okay. Come on now. Breast,
Uterus, bladder, bowel, lochia,
episiotomy, / incision. You guys stink at this now. Bowman sign. Okay. E. We take prenatal vitamins for what reasons? What? The vitamin Bs, right? Because the vitamin Bs have been known to help with suppression of the effects of baby blues, with mood stabilization. Emotions are a hard thing. I was humbled as a mother, I was humbled as a nurse to understand what this means. Okay? Your hormones, your estrogen and your progesterone levels are shuffling very quickly after delivery. And sometimes the way in which we cope with things completely goes outside of what our normal baseline is. I'm not a big crier, but after I had my first daughter, oh my God, I was holding her, and the one day I was crying because her earlobes, I thought, were the cutest earlobes in the entire world. True story. I was also crying at the exact same painfully staking like snot, tissues, red eyes because my husband didn't fold the socks the right way. Okay, so I need you to understand, for somebody who's usually cool, calm, and collected and keeps her stuff in order, I didn't know how to handle my emotions. And sometimes I was crying because I didn't even know why I was crying. And sometimes I was cursing words that I normally wouldn't want to say because I was just really happy, really angry, really sad, singing to the baby, crying over the baby, all over the place in 15 minutes. And the support people in these patients' lives may not know how to handle that. So this part of the education should go across the board. You should teach this to the support person as well, but this piece here, you really should take a little bit of time to discuss it to everybody that's in the room that helps the patient, the mother, okay? So you're gonna explain a couple things. You have postpartum blues and postpartum depression. Postpartum blues is 1 to 3 weeks. Fluid-like emotions, happy, sad, angry, all in 15 minutes. But you still love the baby. And you still have a purpose. Meaning, like, you're getting up, you're brushing your teeth, you're eating your cereal. You might not eat for a couple hours because the kid's been breastfeeding for the last 6 hours, but you're trying to get these things accomplished, right? You're not isolating yourself in a bedroom, not talking to anybody. You have a purpose to your day and a bond with the baby, right? You still look at the kid. You might not be thrilled that she pooped up her back for the 3rd time in the middle of the night when you haven't slept for like ever it feels, but you still love the kid, right? That's postpartum blues, 1 to 3 weeks. Postpartum depression is greater than 3 weeks, or you don't have a bond with the baby and a purpose in your day. Okay? So it can be both, or one or the other. So if these fluid-like emotions are still out of control in your past 3 weeks, we're now thinking we're heading into postpartum depression. Or if you just don't love the kid as much as you would think you should, you know that there's a red flag somewhere, you gotta talk to somebody. Or if you notice that you're isolating yourself, you're not wanting to socialize, and somebody in your life tells you that, like, hey, you're not your normal self, are you okay? That's something you need to be addressing. So, when you explain this to Mrs. Jones, our patient, you're gonna say, do you know what postpartum blues is and what postpartum depression is? And she may say yes or no. And if it's her 6th kid, you're still gonna say, well, I'm gonna give you a refresher on it. 1 to 3 weeks, fluid-like emotions, happy, angry, sad, but you still love your baby and you have a purpose in your day. Do you understand? Absolutely, she says. Postpartum depression is greater than 3 weeks, where you isolate yourself. You may not have a bond with your baby. You may not feel purposeful in your day. And you're still all over the place hormonally. You gotta talk to your OB doctor because that's considered postpartum depression. And do you know how long postpartum depression can last?
Years.
1 year. So, I need you to understand it's a serious thing. And most women, when their child becomes 1 year old and they have that first birthday and their kid's toddling around and smashing the cake in their face and everything's good, that's usually when the mom starts to come out of that depression. Which is why a lot of moms will say, I hated that first year, but it's great now. But did they hate it because they were suffering and they didn't know it? Maybe. And had they known it, maybe they could have had some talk therapy or gone on some medications to help her cope until she hit the year mark, right? So now that you understand the difference between postpartum blues and postpartum depression, Mrs. Jones, are you having any thoughts of harming yourself or your baby? Those words need to come out of your mouth during this clinical. If you're not comfortable with that, drive in your car and say it out loud as you come into clinical so you practice. The reason why I'm going to have you say that is because 1, you aren't going to want to ask that question because you're afraid of the answer. 2, you're not going to ask that question because you don't want to piss the patient off. Imagine, do you want to kill your baby? What are you getting at, lady? You think I want to kill my kid? Right? So you don't want to have that either. So I need you to understand when you ask this question, you need to do it with education first. Do you know what postpartum blues is? Do you know what postpartum depression is? Explain both. Now that you know the difference between both of them, are you having any thoughts of harming yourself or your baby right now? And she'll tell you yes or no. But if you go in and you say, home and sign, okay, Mrs. Jones, you don't have any blood clots in your legs. I have another question to ask you. Do you want to kill yourself or your baby? It's a little bit abrupt and intrusive. I've had students do that because I know students, you want to just like check. Be mindful, this is real life stuff. And emotions are a hard thing to talk about because it's not black and white. And you don't know your patient's baseline, but they do. So if you explain this correctly and explain this correctly, they'll give you the answer that's honest. Okay? If a patient ever says yes, they want to harm themselves and their baby, or their baby, what are we doing? Psych eval. Am I leaving the patient's room?
No.
I'm going to call from the phone in the room, and I'm going to ask for staff to come in. And we're going to do a one-to-one with the safety sitter. We're going to remove all cords, laces, anything that could potentially be involved with a suicide attempt. Yes? Okay. All right.
So if they just had the baby though, that time frame doesn't
Apply. Do you know that postpartum blues can begin even before they deliver? They can have antenatal depression. So most women are going through a little bit of antenatal depression before they even deliver. And they're sleep deprived and their nipples are on fire and they just sneeze and they see stars. And their mother won't get the hint to go home. And their husband didn't fold the socks the right way. Right? And she was supposed to get her mani and pedi 2 days from now, but the kid came early. And now she's got hairy legs and unclipped toenails. You know, people will cry over the craziest things. It just needs to be, is it appropriate for what we're dealing with? Okay? All right, go through it. Do this one the best, please. Breast,
uterus, bladder, bowel, lochia,
episiotomy, /incision,
incision.
And what's the last one? You should have done it in the beginning with your blood pressure. The 5th vital sign.
Pain.
So really it's bubble he, but bubble hep seems to work the best. Don't ask your patient if she's in pain after you just spent that entire hour talking. By the way, it took me a long time to go through this mnemonic. When you get into your patient's rooms, you're gonna fly through it. You're gonna be really surprised. It takes all of 5, maybe 10 minutes with questions to go through. I just wanted to make sure that I hit every topic and every avenue of each topic so you guys feel comfortable with providing education. When you do your patient's assessments, let me be clear. You explain the breasts first, what you're looking for, and then you check. You explain the uterus. All you have to explain to her that it's supposed to move down and she might feel crampy. And then you ask if you can check it. Her bladder. You can't check her bladder, but you're gonna ask her questions about it, right? Her bowel, you're gonna educate and ask her questions about her bowel. Her bleeding, you are going to check her bleeding. You're gonna roll her to the side, check her pad. And you're also going to check for episiotomy or laceration. And then we're gonna roll her on her back, and if she had an incision, we'll check the incision. Make sense? But you're gonna educate. Homan sign. Educate what a DVT, deep vein thrombosis or blood clot is. And then you're gonna ask her if she has any calf pain. Make sense? And do pedal pulses and edema. Explain postpartum blues and postpartum depression. Ask her the question, do you have any thoughts of harming yourself or your baby? It's a little awkward when you end on that note. So really, what I would finish up in the conversation, I would just say, I covered a lot of information. So I expect that you'll probably have some questions. Do you have any questions right now? And if you don't, I wanna make sure that you feel comfortable to ask me questions in the future if you do. Jot it down, write it down, so the next time I come in, it's like, right there. Okay? And thank you so much for letting me take care of you today. Your assessment looks great. And that's it. Okay? Questions?
That's not good.
It's a lot to do, but it's totally doable. And then can somebody hit that button off? Because I'm done talking about the bubble head. Ah. Woo.